I'd like to say good morning to everyone. Thank you for joining us for today's vertical integration, endometriosis. Now, I am joined this morning by Dr. Jason Mack. Before we begin, I'd like to acknowledge the traditional custodians of the land that we are meeting on today. For myself, that is Darkinjin country, and I'd also like to pay respect to elders past, present, and emerging. Now, before we get into today's session, had a few rapid fire questions to ask Jason so we can get to know him for those that don't know the wonderful Dr. Jason Mack. Now, I'll start a little less and then we'll kind of progress into it, Jace. Tea or coffee?
Well, it was tea and coffee and lots of coffee until I went into AF actually a couple of months ago. So I'm off coffee and alcohol altogether at the moment. But yeah, I'll take a long black once I've recovered.
Perfect. I like that one. Another easy one, sweet or savory?
Savory.
Same. Your favorite beach on the Central Coast?
I love Spoon Bay on a good day when it's flat. It's good. It's fun for the kids for a snorkel on low tide.
Yeah. Nice little experience down as well, which is always good.
Yep.
Window or aisle seat?
Window.
I like how it's like direct. Easy one there. And next one, your biggest learning experience to date, preferably like related to your work.
I think my fellowship experience that I came off the back of a couple of years ago with Alan Lamb and George Condis. So that for me was that was really world-class surgeon sonologists that I wanted to emulate. So yeah, working with the guys that I kind of really have a lot of time for. Best experience, and learning from patients. Sorry, that's not really one answer, is it?
That's okay.
I learn a lot from patients.
Yeah, beautiful. Well, thanks for answering my questions today, Jason. I'll let you get into it.
Thanks, Sydney. So if I so I'm going to go full screen on this now. Is everyone seeing that?
Looks good.
Yep. So in case everyone's not here by the time I finish, if I bore you to death, I'll just give myself a plug now. So I've just taken over Peter Nelms's practice. If I haven't really done any promo or anything like that. So the website on the bottom right there, it's not up yet, but it'll hopefully be up in about 2 or 3 weeks. But you can find me at in the public clinic, but also now I've started a private clinic as well. So this is the course curriculum. These are the things that I think we need to cover, and I think in a little less than an hour, if we get across these topics, I think I can have you understanding endometriosis better than most gynecologists. So we're going to see what the disease burden is, what the disease actually is, a disease definition, what the pathogenesis is. We'll do a little anatomy refresher for anyone who likes anatomy, and cover diagnosis and treatment. So endo is there's a huge disease burden. It has got a lot of media attention in the last few years, and that's actually really a good thing because traditionally it's really been an underdiagnosed and underappreciated condition. The incidence is quoted to be around 11%, and if you take that at face value, if the incidence is 11%, I did a little bit of maths on the Central Coast. The population's 346,000. 51.5% of the population is female. 46.8% of the female population is of reproductive age. And if you multiply that by 11%, that means we've got about 9,200 women on the Central Coast that you would expect to have endometriosis. But I put an asterisk next to the 11% because the true incidence is probably higher. These are confirmed diagnoses, and many women go through their whole life without getting the diagnosis. That 11% comes from a longitudinal study, the Australian Longitudinal Study on Women's Health, and that comes from 1989 to 1995, so a cohort back then. So it's probably higher than that. Globally, they say the incidence is 10%. Globally, the disease burden is probably estimated to be about 190 million women. But yeah, like I said, it's chronically misdiagnosed, underdiagnosed, and underappreciated. So this next little set of stats comes from a survey of 451 women in Australia, and it was about 5 years ago, and they described that only 10% of women get the diagnosis on the first consultation. About 2/3 take up to 10 consultations. 7.5% take 20 up to 20 consultations, and 30% of women take more than 20 consultations to get the diagnosis, and that equates to about a quarter of women having a delay of between 6 and 10 years. It's not uncommon for me in my clinic to see women, like often the classic situation that they describe is they have to go through all these hurdles to score the diagnosis. So initially, you know, classically that from menarche, so from age 10, 11, 12, when they have their first period, they're having debilitating pain. And so they describe that to their family, and their family members usually tell them, well, periods are supposed to hurt. So there's nothing special about you. They tell, friends, teachers at school, get the same kind of response. And it's usually not until they're, a bit older in their 20s that they might actually seek advice. Often the family members will kind of be still telling them that there's nothing wrong with them. And obviously not you guys, because you're all totally switched on and coming to this presentation, but often there's a delay at the GP level. But it's not just at that level. Even at the gynecologist level, you'd be quite surprised how many gynecologists miss the diagnosis or get it but don't quite get the treatment or the surgery right. So there's a chronic delay, and that's something that I think is really improving now with subspecialization of complex benign gynecology in our specialty. Anyway, it's the most common misdiagnosis, anxiety or depression, or classically irritable bowel syndrome. So often, any of your female patients that have irritable bowel syndrome, you've got to really make sure you ask them, are the symptoms that they're getting bloating, abdominal pain, dyschezia? It all sounds very much bowel and irritable bowel, but ask them if it's cyclical, and that's the key. So that last little stat, 7.4 billion. So that was done in 2019. Ernst & Young was given the job by the federal government to calculate what the economic cost of the disease is in Australia. And even they noted that the incidence of 11% was probably an underestimate. But based on the 11%, it would be about $7.4 billion in economic damage just from lost revenue. You guys all know, your patients that have endometriosis spend a lot of time missing school and work and are not able to care for their children. So all the knock-on effects from that, that's what Ernst & Young figured. You guys still with me?
Yes, all good.
Oh, good.
Thanks, Jason.
Sydney said make it didactic, but I'm not very good at that. So, but please just interrupt me if you guys have any questions, or if you have any comments. Any questions so far?
No questions in the chat box, but feel free, everybody.
Cool. We'll sing out the questions as they hit the chat box as well, because I can't see them. Can you see the screen? It's going to get a little bit experimental here. I'm just going to do, is anyone like anatomy? Know their pelvic anatomy? Because we're going to look at a lot of videos and photos. So I just want to do a bit of an anatomy refresher. And I don't know, I'm using a mouse, so this could get a bit interesting, but we've got a uterus, right? So uterus is a upside down pear-shaped muscle, and it sits atop of the vagina. So can you see my pointer as it moves?
Yes.
So you guys know what this is. That's obviously the cervix. We've got our tubes. And then if we're looking down at the pelvis from the laparoscopic view, we're going to see two big ligaments here. Anyone know what they are? You're going to get familiar with them. And if you do a vaginal examination, often when it comes to endometriosis, you'll feel these ligaments just off to the side of the cervix. And they're the uterosacral ligaments. So they're right at the bottom of, they're the lowest drainage point in the abdominopelvic cavity. So they're, often where endometriosis finds itself. And so they're a classic spot for endo. I'll show you some pictures of what that looks like. So then we've got obviously our ovaries. We've got our, sing out if you know the names of any of these structures that I'm drawing. We've got our ovarian ligaments that supply blood as an anastomosis that comes up from the uterine artery. So the uterine artery comes up, and then across and supplies the ovary that way. And then the infundibulopelvic ligament brings it down that way. On the pelvic sidewall, we've got our ureter and we've got our rectum. And the yellow fat off to the side of the rectum is called the pararectal space. The broad ligament is the big sheet of ligament that runs off to the side of the uterus. Anyway, that's probably enough for now, and we could talk more about that. That's just to sort of give you your bearings as we go through some of these slides. So like I said, there's you've got a big upside down pear-shaped container called the uterus, and it's got 3 layers. So the outside layer is the serosa. Whenever you hear the word serosa, it's just another word for visceral peritoneum. So we've got peritoneum on the outside, then we've got a big thick muscle layer, and then inside the cavity we've got our endometrium. So the myometrium is the big powerful muscle layer that's supposed to push babies out. And then the endometrium is the lining layer that sits on top of that. And so you guys know this, but endometriosis gets its name from endometrium, which is this layer, and it's purely ectopic endometrium. So I've put this image here. This is a hysteroscopic image. So this is a camera in the via the vagina in the cervix looking at the fundus from inside. And this is a good way to start to imagine the different morphologies of endometriosis. So this fluffy pink stuff, and as you remember, its job is to grow, get more vascular and more glandular towards the point of ovulation. And then every month, if there's no pregnancy, its job is to degrade and then shed with a bunch of bleeding, and that goes out the door, and that's called a period. But every month it regenerates, so it's this regenerating layer. It's got a very special role. It's only supposed to live in the uterus. But see how this little spot in the middle of the screen looks a lot like this last, one. If you were to scoop some of that out and just throw it at the peritoneum inside the abdominal cavity, that's kind of what it looks like. So that's early endometriosis. Then what happens is there's an inflammatory reaction. So you can see some white kind of scar tissue starting to spider its way in towards this fluffy endometrial looking stuff. So there's a reaction there. And then if you guys probably would have done a few laparoscopies and seen some endometriosis in real time. And probably the most classic one you would have seen would be these little black spots. Would that be about right? You guys picture endometriosis looking like this? All that is this same pink stuff, and the peritoneum's just grown over the top. And so then you have endometrial tissue that still goes through its cycles under the influence of LH, FSH, and estradiol and progesterone, so which is interestingly under the influence of the cycles of the moon every 28 days. So it still keeps going through its cycles, and therefore it's painful, and it keeps generating more of a reaction from the immune system. So you leave it there a bit longer, it starts to look more like this. This is sort of, a lump of endometrial tissue that's really been covered over. And I like this picture because it shows you some early endo there as well. This is a classic morphology, that kind of gunpowder burn marks where you get little clusters of endometriosis that have found themselves This one's sitting on the bladder. That's the fundus of the uterus in the foreground. Remember, we talked about the uterosacral ligaments being a really classic spot. This is endo, deep infiltrating endo. I mean, back in when I even started my training, people would just burn the surface of this, and it did absolutely nothing. And all the research shows that just diatherming the outside of a big lesion like this doesn't help the woman. You've got to actually really excise it deeply. This is going to track right down into the uterovaginal septum. It's going to be pulling the ureter in from laterally. It's sitting right over the uterine artery as it plugs into the cervix. So it's in a pretty precarious position, but this lesion here is what's going to give them their dyspareunia. So the uterosacral ligament's job is to run from the back of the cervix. The back of the cervix is also called the torus uterinus. If you see that in any of my reports, that's what we're talking about, the torus, and of course the pouch of Douglas, that scooped out area in between the ligaments sitting in front of the rectum. So that ligament running back down there, its job is to hold the cervix still in the pelvis. And so its job is to stretch, obviously, when you go to have sex. So when you're having sex, this ligament is supposed to stretch. When it's full of endo, it can't stretch and it's really painful. So that's why they get their dyspareunia, their pain with sex. Classically, when they've got endo on these ligaments. Make sense? There's blistery sort of morphology as well. So once it starts to get really ugly and things start to get stuck together and anatomy starts to get distorted, this is often missed by gynecologists, is the little subtle pocket or crypt or fenestration. So the little Swiss cheese hole, that's often deep endo pulling down and often missed. And this is a big lesion here. Can you see my pointer where it's waving? Sort of. Maybe I'll just
Not at the moment.
Not at the moment. Let me go laser pointer. How's that? Can you see my
Perfect.
laser?
Yeah, laser's great.
So here's our mates again, the uterosacral ligaments, which remember the vagina sits at the back here. So if you are doing a vaginal examination, you can feel easily out to the side and feel these ligaments and feel if they're thick and nodular. You can feel the rectum, you can feel rectal nodules here. And of course, a transvaginal ultrasound gets a direct look at all of these. So we'll talk more about ultrasound in a bit. So this looks like not much, but that is actually a massive rectal lesion that is sticking the rectum up against the left-hand uterosacral ligament. Oh, now I've got a laser pointer. I can't change my screen. Here we go. I'm going to get rid of that. Now, let me see. Sorry, this is a video, but I'm just not sure. Is it going to play? Here you go. Are you seeing that play?
Yes.
Good. So you can see the assistant trying to scoop the bowel away so we don't inadvertently burn it, but that's a giant endometriosis. That's the ovary. It's got little black spots on the outside. So really, no one really knows, but my theory and Alan Lamb's theory, a lot of people think that you get these superficial lesions on the ovary, and the ovary is so plastic, that it recovers after having ginormous cysts on it and surgery. It morphs around and wraps itself around surface endo, and then that surface endo becomes a cyst, and then that's a giant cyst, that one. This is what you call kissing ovaries. Pretty cute. So you got two ginormous endometriomas, one on the left, one on the right, and they're fused together in the midline. And you can see the can you guys see me?
Yes.
Oh, you can. So you can see the tubes wrapping around and giving a big hug to the ovaries. Whenever there's endometriomas, if you see bilateral endometriomas that are stuck together when you push them with the transvaginal ultrasound probe and they move together, there's a 40% chance when you see that there's going to be a rectal lesion. This is a completely frozen, obliterated pelvis. So hard to make out what's what, right? I think I've got these labeled. So that's actually the uterus, the left ovary, and that's bowel stuck to the back. And the right ovary is buried down there. Lots of adhesions. So that's what you'd call, definitely stage 4 endometriosis and really frozen pelvis. That's the ureter. And that's what you'd call a retroperitoneal dissection, to try and get down and identify those vital structures, the external iliac artery and the ureter. And that's the IP ligament, the big artery that supplies the ovary. Beautiful, isn't it? People that haven't seen endosurgery before just think, what are you doing? This is looks like a mess. It does look like a mess because there's so much disease everywhere, and the more you uncover it, the uglier it gets. But the point of the surgery is to get, like with cancer, maximum cytoreduction and restore anatomy, and that restores fertility and improves pain. So this is just to remind me, there's two main theories of pathogenesis for endometriosis. So no one really knows, but I'm pretty sure we know. We kind of know that it's possible for something called coelomic metaplasia. So the peritoneal tissue comes from the same embryological origin as the endometrium. And so because they have very similar DNA, then it's possible for metaplasia to occur. So we know that happens. It can just transform from one cell type to another. We know it happens because you occasionally get endometriosis in the pleura or even in the meninges, and even you can get that in a male. Very, very rare. I haven't seen it, but that's possible. Probably the most common way that endometriosis happens is that's a picture of Mr. Bean's face overlapped over one direction, but it's the wrong direction because that's what happens with the so it's retrograde menses is the other main reason for it. So when I was growing up and we were taught the pathogenesis of endometriosis, it was that retrograde menses is the disease. So the period should go out through the cervix, out through the vagina, and out the door, but only when there's a pathological process will it backflow out the tubes and into the peritoneal cavity. Actually, we know now that it happens virtually every woman, every period has some element of retrograde menses, which makes sense because the two cavities want to communicate with one another. They probably communicate via the biome, so via the bacteria, healthy bacteria that live in the uterus. There is a microbiome in the uterus, and it does communicate with the peritoneum for reasons that we don't know that are probably important. But we know that from studies that look at women who have peritoneal dialysis that are menstruating, you can centrifuge off their peritoneal dialysis and you'll find endometrial cells in virtually all women, even ones who don't have endometriosis when they have a period. So the pathology is not that there's retrograde menses. The pathology is that the immune system fails to mop up those endometrial cells. Does that make sense? And is that kind of what you guys remembered of the pathogenesis of the condition?
Jason, I'll just feed back that this is fascinating.
Oh, good.
And I went through medicine a few decades ago, and some of this is really new and really interesting and makes a lot of sense of people's symptoms. So thank you.
Yeah, it all makes sense, when you figure it from the whole loop of pathogenesis to what's going on. I mean, this is all theoretical, but there's probably, if you look at population data, women who are in Southeast Asia and Africa, there's pretty low, seems to be low rates of endometriosis. And the obvious answer for that is, well, you probably don't have endometriosis surgeons and it's getting underdiagnosed and underrecognized. But also they have a very high parity. So in countries where there's a very high parity, they have 10 or 12 kids. And in the olden days, when everyone had 10 or 12 kids, because they needed a few spares, then there's pretty low rates of endo. And it's probably because if you spend your whole life, probably as we were designed evolutionarily to have periods from the age of 10 to the age of 50 and be pregnant or breastfeeding virtually the whole time, there's not much opportunity for retrograde menses. So that kind of makes sense. My personal theory, which I'm working on, is also that we go to the toilet wrong. And so if you're sitting on a Western toilet, you're actually cutting your you guys know this. You've probably seen the Squatty Potty ad, and you guys know all about pelvic floor health. But it's actually in countries where people squat to poo, there's also low rates of endometriosis, because the way we poo is we're not really emptying from the back of the sigmoid, we're only emptying the rectum below the pelvic floor, and we're cutting it off early. So if you leave yourself constipated chronically, then you put transluminal pressure on your gut. And if you can imagine what that probably does to your immune system, I think it's the small bowel that's wriggling all over the pelvic cavity with its Peyer's patches, which are the lymph nodes. Those Peyer's patched lymph nodes from the small bowel are probably what is supposed to pick up that endometrial tissue. So if you've got bad gut health from alcohol, antibiotics, and from just the way we go to the toilet all wrong, then I think that's also contributing to our high rates of endo. But I'm doing a study to prove that at the moment. Anyway, so the clinical outcomes, the best way to remember it is the 4 Ds. So dysmenorrhea, painful periods; dyschezia is pain opening your bowels; dysuria, pain going to the toilet; and dyspareunia is pain having sex. So if you remember the 4 Ds, the classic dysmenorrhea is that they get the pain in the build-up. So the pain sometimes starts a week before the bleeding starts. So if someone says they got period pain, well, everyone has period pain because all periods are painful. But when does it start? The timing is usually in the build-up, and then it sort of peaks on day 1 or 2, and then it's cyclical: dysuria, dyschezia, dyspareunia. So notice the pain obviously has that cyclical nature to it. And then there's a lot of theories around how it affects fertility, but it's pretty easy to imagine if you've got a hostile environment surrounding your uterus, then there's an inflammatory exudate that drips backwards down the tube. All kinds of cytokines and chemokines have been implicated, and natural killer cells and all of that sort of stuff. But it's just general inflammation, really. So you've got a generally inflamed, angry pelvis. That's not a friendly environment for a blastocyst to implant on the endometrium. So you've got an inflammatory barrier to implantation, but you've also got anatomical barriers. So in some of those photos that you've seen and that we're going to show in a minute, you can actually see pretty distorted tubes, completely blocked tubes. So you can't have a pregnancy with blocked tubes, and the ovary completely smothered in endo or caked up against the pelvic sidewall. It's not going to be able to ovulate and land that ova in the fimbria of the tube. So correcting the endometriosis improves fertility. So that's been well and truly proven. So it is a myth, I think, started by the IVF guys that surgical treatment of endometriosis doesn't help fertility. They will advocate, it's an ongoing debate that you'll see in journals and at conferences, but the IVF guys think that the answer is IVF, obviously. And then the surgeons think that the answer is surgery. It's probably both. Really, most women will fall pregnant in that 6 to 12 month window after surgery. And if they don't, their IVF success rates are better than if they hadn't had the surgery. So that's been well and truly established. So diagnosis was always thought to be via surgery. So that image is to remind us of laparoscopic surgery. That's Patrick Steptoe, the inventor of IVF, doing some very early straight down the eye hole laparoscopy to collect eggs. And the sonar, same sonar that's used by submarines, that's ultrasound. So the gold standard was always thought to be, if you wanted to diagnose endometriosis, you had to do a lap. You had to put a camera in the belly and see it to believe it. But the new 2022, actually 2 years ago, not that new, ESHRA guidelines have confirmed, with all the evidence that we have now from ultrasound, that ultrasound is the new gold standard. So it's as specific as surgery, but it's not as sensitive. So if you've got a negative detailed endometriosis ultrasound, if it's negative, then you haven't ruled it out, then you would still need surgery to rule it out. But if you see endometriosis on the ultrasound, that is as good as surgery at diagnosing endo. And in fact, in some anatomical locations, it's better than surgery. So you can kind of imagine how sometimes you can be fooled and think that the pouch of Douglas is intact, but actually it's just been pinched up against the back of the uterus or obliterating those uterus sacrals, and there's a big deep lesion underneath. Those lesions are really easy to see on ultrasound, but can be tricky on surgery. So really there's no excuse for not having a proper detailed endometriosis ultrasound. This is what endo looks like on ultrasound. You know, back in the early days of endometriosis ultrasound, this was about all you'd get. I'm pointing, you might not be able to see it, but I'm pointing at the top left image. That's kissing ovaries. So remember that image of kissing ovaries that I showed you before. That's what it looks like on ultrasound. The classic appearance is this ground glass. They call it ground glass. I reckon it's old, if anyone remembers old TVs, the snow on the TV. It looks like snow on the old school analog telly. So that ground glass or snowy TV appearance is classic chocolate cyst endometrioma. So they're kissing. The really important part of endometriosis ultrasound is that really the gynecologist or the surgeon who's going to do the surgery should be doing it, because there are a lot of dynamic moves that you can't see when you just see the still images or when you see someone else's images. Because what we would do is we would want to push the probe up against those ovaries and see if they're anchored, see if they're anchored to one another, see if they're anchored to the pelvic sidewall or to the back of the uterus. The top right image is called a Diablo lesion, so sort of that Diablo shaped lesion hitting the back of the vagina and the torus urinus, and that's a bowel lesion pulling up onto it. You can see in this bottom image what corresponds to the anatomy of the wall of the bowel. So the black stuff is the muscularis. So muscle is got water in it. Water is usually the fat is more hypodense and the water is usually more hyperdense. So the muscularis, the muscle layer of the bowel, shows up black, and it should be this thin strip here, whereas that thickening is what tells us there's a lesion. And it's usually the patient's symptoms have us having a pretty close look too. This is the IDEA protocol for how to do an endometriosis ultrasound. So there are a lot of people that say they can do endometriosis ultrasound, but there's really only a handful who are properly trained, and it must follow this protocol, looking at the anterior compartment, the bladder, looking at the ureter, looking for the ureteric jets, which you can actually easily see on ultrasound, looking at that dynamic move. Is the bladder and the uterus stuck in that uterovesical fold? Same in the back, in the rectovaginal septum, looking at the uterosacral ligaments, following them along, looking at the torus, pouch of Douglas, obliteration, and a lot of even just neighbourhood radiologists that aren't necessarily women's health radiologists or know what they're doing for endo. A lot of them are now commenting on those sliding signs, which is good. So because it's pretty easy actually, and it just means you're pushing the ultrasound probe against the cervix and seeing, does it slide nicely over the back of the sacrum, or does it go up with it? So they're the signs that we look for, and then you can actually really see the lesions. In terms of treatment,
Jason, do you mind if I just ask, do you have a place that you would send your women for the ultrasound? Like, do you have a trusted?
Yeah, so the guy who taught me was George Condis, and he's on Omni Ultrasound in Sydney. And I've been trying to start an endometriosis ultrasound clinic at the public hospital for the last year and a half without much success. But fortunately, I don't have to wait for permission now. I've got my own clinic, so I've just ordered a Voluson Expert 20, which is one of the most pimpin' ultrasound machines on the planet, and it's going to arrive in about 8 weeks. So in about 8 weeks, we'll be running an ultrasound service at my practice. Hopefully, we'll be able to mirror that in the public as well for women that that want to go public. So pretty soon, hopefully on the Central Coast, we'll have a really good public and private option for women with pelvic pain. But in the meantime, the options are send them from an MRI, which costs about $800 out of pocket. It's not covered by Medicare, so it's too expensive really, and it's not as good as ultrasound. Or send them to George Condis at Omni. They've got rooms in the city and St Leonard's and at Nepean. There's only one public unit in Australia, and in fact in the world that I know of, that does proper detailed endometriosis ultrasound, and that's Nepean, where I trained with George. And if we can get it going at Gosford, that would be the potentially second unit in the world where you have a public endo ultrasound. So that'll be an achievement for us. As you guys know, the treatment is all about there's surgery and hormonal suppression is the mainstay, but that's not the end of it. But in terms of the hormonal treatment, the best analogy I ever heard from my boss Peter Bland is estrogen. If you think about the endometrium as a lawn, estrogen is the fertilizer and progesterone is the lawnmower. So estrogen makes it grow up, and then progesterone suppresses it. So it's usually progesterone-based medications that work at thinning down the endometrium and therefore the endometriosis. And so the question usually is, well, how the hell does the combined pill work then? If estrogen is the fertilizer, and that's if you give unopposed estrogen, so often unopposed estrogen at HRT will set a woman who's just finally said goodbye to her last period and thinks she's not going to have any more endo pain, and she gets HRT, brings it all back. It's unopposed estrogen that will cause a flare-up of endo. If you give the combined pill, remember what you're doing is you're giving a little bit of estrogen and progesterone, but you're overall lowering the estrogen because you're providing that negative feedback to the pituitary, the LH and FSH, therefore it gets negative feedback, and then your ovaries produce less estrogen. So you give a little bit of estrogen and progesterone in the form of the combined oral contraceptive pill, and your natural estrogen production is lower. So overall, that is why it shrinks. So almost, always that should be the first line. But a lot of women, and you guys would know this better than anyone, really have a lot of trouble with the pill. So, it's not for everyone. Some people get really bad side effects, mood disturbance, weight gain, mastodynia, sore boobs. The other treatment that we use a lot at our level is the GnRH agonist, Zoladex. So if the pill works, or if the marine, so everything other than GnRH agonist works equally well. So Mirena, the pill, Implanon, Depo, they all are, none of them, and even the expensive versions of the pill and the ones that are marketed to be especially for endometriosis, none of them have ever been proven to be better than one or the other. So I always just go microgynon because it's cheap. It's only $3 a month instead of $40 a month. Works as well as the fancy ones, and you can tweak the dose of estrogen up or down. But Zoladex is much stronger than that. So it completely suppresses the LH and FSH as a GnRH agonist, and then it completely drops the estrogen levels to zero, to menopausal levels. So they get quite a few vasomotor symptoms with it. So usually a little bit of add-back therapy with some tibolone or a little bit of low-dose estradiol when we give Zoladex. That's either a monthly injection or a 3-monthly injection. And because we're giving them a chemical menopause, then they're going to get osteoporosis if you use it for too long. So 6 months is pretty safe. Beyond 6 months you've got to do a bone mineral density scan. It's not a long-term solution, but it can buy you a bit of time if they're on a 12-month public waiting list and they've got debilitating pain. If it's really bad endo as well, you kind of want to know if they're going to respond to the Zoladex, because if they have the Zoladex and say it didn't help me, then it's not really worth doing a bowel resection for them and putting them through all that surgical risk, because the Zoladex gives you kind of a simulation of what the symptom improvement is going to be that you're going to get from your surgery. So it's a good option in some situations, but it's not a good long-term option. And then it's really important to have a multidisciplinary team. And I put, you guys are at the middle of that picture. The GPs are the gatekeepers of patient care, and you're really important for their ongoing, analgesia requirements and, coordinating care. But you obviously need a gynecologist who specializes in endometriosis. You need a anaesthetist, not just for surgery, but for chronic pain specialists. You need a bowel surgeon. You might need So I work with Kelvin Kwok. He's great, and we're doing a lot of combined cases now. We've been doing it for the last 12 months. Pelvic floor physios are absolutely vital. So if we've got time, I'll just quickly explain, have you guys heard of the concept of pelvic floor instability syndrome and how that relates to chronic pelvic pain?
Tell us more, Jason.
So you've obviously got a pelvic floor, so it's a sort of a trampoline of muscle that sits across the pelvic outlet. And the way I explain it to women is there's 3 holes in it. There's a pee hole, the urethra, there's a vagina, and then there's an anus. So that pelvic floor has a lot of complex connections and a rich neural supply, and it becomes a little bit like the gatekeeper of the pelvis. Now, a bit like with chronic lower back pain, everyone's had a bad back at some point, right? Almost everyone has had a disc or something go out. When you have that day where your back just goes and you can't get out of bed, really there's no threat to your spinal cord, because the spinal cord finishes halfway down. But down at your L1S, whatever down there, lumbosacral spinal levels, when that little disc comes out and causes inflammation, it's the paraspinal muscles trying to splint your back. So it tries to splint it like a splints a broken bone to keep it safe. And it thinks it's doing you a favor, but it's causing immense pain. It doesn't actually achieve anything. So everyone kind of remembers that mechanism for lower back pain, but it's the same that happens with the pelvic floor. So if there's been some disease, some inflammatory, angry process that's going on in the pelvis, well, the gatekeeper of the pelvis is going to spasm and try and keep things out. It's only got 2 buttons. It's got an on and an off button. So it's supposed to, contract when you go to lift something or catch something or brace yourself or exercise. So it should be activating to hold things in when needed. Cough, sneeze, laugh. It's a continence mechanism. But when you go to use your bowels, empty your bladder, or have sex, it's supposed to relax. So it's supposed to coordinate a relaxation. But instead of that, it starts training itself to shut the door. So it wants to protect its boss. So it says, nothing's going in or out, I'm going to spasm. And it's that spasm that gets, over years and years and years, gets stronger and stronger and more hardwired. So whenever they go to have sex, go to the toilet, that spasm kicks off. Or even sometimes you'll hear of women with endometriosis getting that pain with exercise. Well, that's why, because their pelvic floor goes to activate just in the normal way when they exercise, but it's so hardwired to spasm, it can't get out of it. That's why women will get that pain during sex, that dyspareunia, but they also get that postcoital pain that can last for hours, even days. Women will describe, I just have this cramping pain that goes for 48 hours after sex, and so they can't even have sex anymore. So that's what that is. That's that pelvic floor. Now, the pelvic floor physios are real wizards at unlocking that. So they literally just put a finger in the vagina, feel the levator muscles, feel the obturator internus, press on it, find out which ones are spasming, teach the woman where those muscles are and how to find them, and not how to strengthen them, but how to relax them. So if you send them to the wrong physio, the physio will go, I know how to strengthen the pelvic floor. We've got to do Kegel exercises. Well, that's going to make them worse. So if you try and activate the muscles, it's going to make the pain worse. What they've got to do is deactivate them. So they're going to press on those muscles, desensitize them, and teach the woman how to take control of them and switch them off and relax them. And it sometimes works better than anything I can do with surgery or hormones. So pelvic floor physio is really important. And psychologists as well. Unfortunately, there's with any chronic pain, there's anxiety, depression, and with such a long lag time between diagnosis and onset of symptoms, there's usually, it's hard to unlock. There's sadly as well women who have residual pain after they've had a lot of treatment for endo. I kind of make a point of asking them about it, but there's usually, unfortunately, very much higher rates of childhood sexual assault and sexual trauma and even rape in the population of women who have chronic pelvic pain, whether there's endo there or not. And so, the best psychologists I've found are the ones from victims of crime. They're free and they're really, really good at dealing with that sort of thing. So that's definitely their area, not mine. But it's a good thing to screen for is previous trauma. So we've got a little bit of time left. I'll just whip
Okay, so
through.
we have a few questions. Would you refer them at the end, or?
Yeah, why don't we do them now, because the rest of the presentation is just lots of videos and me showing you more endo. So we can probably pause there if you want. I'll just minimize that if I can. Yeah, shoot with the questions.
Yeah, so I suppose we'll start off with, do you have any preferred local public or private pelvic floor physios?
Laura Worthing, yeah, so Laura Worthing, I think. There's also Lexi at Gosford, but Laura is at Weil. So she's excellent. And the best pelvic floor physios I found when I was training and working in Sydney were the ones that had come from WHRIA, WHRIA, which is Thierry Vankei and Jason Chow's unit, and they specialise in endometriosis there. And they're excellent. But they have 2 or 3 physios that really pioneered endometriosis physio in Australia, and anyone that's trained or associated with those guys is usually good. So when I was planning on finishing my training and coming back up to the coast, I made a point of finding out who the physios were, and Laura Worthing came recommended by the other guys that I was already working with in Sydney, and she's great. So I worked pretty closely with her.
Yeah, and then Ruben asked, rather than doing extensive surgery at 25 for women with severe endometriosis, is there a mechanism where we can pick up the girls at 18 and prevent development of severe endometriosis?
Yeah, absolutely. So, I mean, you're right. You don't want to. It's an interesting debate. Is that if you find endometriosis in a teenager, do you operate on it then, or do you just kind of recognize it and try and manage it with your pelvic floor physio, your hormonal suppression, etc. But actually, yeah, early diagnosis and early intervention is the key. So there's really nothing wrong with operating on someone at the age of 25, but it's important that you don't just operate on them and then leave it at that. So if you're going to go to the risk and the trouble of surgery, it's important to suppress the endo afterwards and prevent recurrence. So really the best combination is to have, surgery that's complete and that where you get maximum cyto reduction and get it all out rather than just the surface of it. And then a Mirena. Mirena's, my go-to because less side effects. You can put it in and leave it in, and it's as good as the pill at preventing recurrence. So yeah, I think did that answer your question? It's sort of the most important thing that you can do is just diagnose it and get that multidisciplinary approach around people as early as possible. But that also includes surgery. Nothing wrong with doing surgery, even in a teenager that you've tried everything else. It shouldn't be the first option, but it's definitely an option when a teenage girl can't get out of bed and leave the home and is in a torture chamber for 5 or 6 days every month. They're not going to make it through school. So you really want to throw the kitchen sink at them. That includes everything, including surgery.
And so rather than an 18-year-old putting them on the pill to see how they go, we should be sending them a bit earlier.
No, that's the right thing. Yeah, put them on the pill. Yeah, sorry, did I mention that? Yeah,
first. I thought I was like, how soon should we refer? If we can control them on the pill, that suggests that the disease is under control and we can leave it at that.
Oh yeah, no, I'd be guided. Yeah, I think that's fine. I think you'd be guided by their symptoms. First line should always be the pill. But remember, you have some poetic license to have a bit of trial and error. If they have the first pill and they say, oh, no, I got sore boobs or I got like weight gain or it made me crazy, well, you can always try a lower dose estrogen. You can try microgyne on 20, or sometimes you've actually got to go the other way, because if you are not giving enough estrogen, you're not suppressing their hypothalamic pituitary axis, and they're actually getting the estrogen and progesterone from the pill that you're giving them, plus that you haven't actually suppressed their ovaries. So they're ending up with a high amount. So you actually need to push. That's the one mistake even a lot of gynecologists make is, I need to go lower and lower. Actually, sometimes you need to go higher to knock off the ovaries, and then they get the therapeutic effect. And a lot of symptoms are just a bit like with starting an antidepressant. the side effects come before the therapeutic effects. So sometimes you just got to tell them to push on for a month or two. So, but yeah, I'd always start them on the pill as first line, but I would always listen to them and believe them if they tell you I just can't do the pill. It's just like it makes me nuts, and I don't want it. It's pretty like it's even a lot of gynecologists really write off that concept that people complain of a lot of symptoms from the pill and can't take it, and they just say, well, you know, if you can't take the pill, then your endo symptoms mustn't be that bad. Well, they can be because you can get really bad, you know, even depression. Something happens, no one really knows what it is, but I think when you cut off that natural surge in progesterone, or even if you have that natural surge of progesterone, it sort of sends a message to some women that they're virtually losing a pregnancy every time they have a period. So for some women, the pill can give them depression, or some women giving the pill can improve that premenstrual dysphoric syndrome. So yeah, but yeah, it's worth trying different agents. You can do that, and if they're responding, then there's no need really for referral if they're doing well.
Fabulous. And there's a few questions about, you know, some of the new designer sort of pills coming out. So there's a mention of the new GnRH agonist, an estrogen and progesterone pill. Is that more effective? And also, I don't know if this is the same type, but there was a new TGA-approved medication, Relugolix, with estradiol and norethistérone.
Yeah, so the last one that you mentioned, it hasn't really been shown to be any more effective. The oral GnRH agonists I haven't used yet, but I'm going to the AGES conference tomorrow, and there's going to be a lot of talk about it because it's come out in the last 12 months, and there's going to be a lot of talk about the oral GnRH agonist. From the literature, it's as effective as the injectable GnRH agonist, the gosrelin or the injectable ones and the oral ones. They're supposedly equally effective, but they're pharma-sponsored trials. So we kind of need to wait and see some randomized controlled trials come out that are not influenced by the companies that are manufacturing them to really know. My suspicion is that they're going to work, but they're not going to be as good as the injectable ones, because what they say is that women will probably still have a period. So if you're still having a period, then that tells me you're not really suppressing the estrogen levels that much.
Awesome. And there's another question. How do we know that a gynae is specialised in operating on endo? So we know we've got a lot of gynecologists on the coast and obviously to Sydney. Do you have any comments on that?
Yeah, I am. But I mean, I would say there's not many on the coast, really. There's a lot of great generalists on the coast, and most endometriosis can be looked after by a generalist. But there's no one else really on the coast that will be able to do the comprehensive surgery if the endo is bad, or the ultrasound necessarily. So there's a handful. I would say there's probably only, I could probably count on my fingers and toes the number of people in Australia that can do stage 4 endometriosis surgery. So there might be about 10 in Sydney. Actually, probably not even that. And probably just me on the Central Coast at this stage, and no one in Newcastle. So yeah, but I would say if you want to know, because on everyone's website they're going to say they do minimally invasive surgery, I would look at their training. They would want to have done a fellowship in endometriosis or complex benign gynae surgery, and usually, you know, I think if someone's doing obstetrics, that probably means they're spending 70 or 80% of their time delivering babies.
Fabulous. And there was a question, is there a screening blood test in the pipeline?
There's a lot that have been, there are many that have been looked at, but nothing really that's as sensitive or specific as laparoscopy and ultrasound. CA125 has been looked at, and they've tried to incorporate it into some diagnostic algorithms that use ultrasound and CA125 to try and increase the sensitivity, but it doesn't really. It's so CA125 is the best one that we've got, but it's so non-specific. It's used obviously as a tumor marker for the ovaries, and it's still non-specific for that as well. You know, you could have a little bit of a tummy ache and your CA125 will go up, and you can have a lot of endometriosis and have a normal CA125, just like ovarian cancer. So yeah, no good markers. There are a lot of, almost every year you go to an AGES conference or AHL conference in the States, and someone thinks that they've found the marker, and they might have a small cohort study that shows that this new marker is fantastic, and then, you know, it usually fizzles out. So the answer is no. Best thing really is take a really thorough history. Remember the 4 Ds. Remember the premenstrual pain. Ask about those classic symptoms. You know, obviously the dyschezia, dysuria, dysmenorrhea, but also that postcoital pain. Is it positional, and is it really cyclical? So the history, you know, someone's got endo almost the minute they walk through the door, but the history will give it away, and then ultrasound will find it.
Okay, any other final questions? That was amazing. I think I've learned more about endometriosis than in my whole life. And there was a comment that it was insanely helpful. So
very good.
We all agree with that. So and any further questions, feel free to unmute.
Sorry, I probably talked for too long because we ran out of time. I had a heap more videos, but that's all right. Maybe we can do another one in a year or something.
That would be fabulous. And
oh yeah, I was just going to say, anytime you guys want me to talk, I always love it. My mum was a GP nurse, so I know my way around a general practice pretty well, and have a lot of appreciation for what you guys do. I'm only smart enough to remember one disease. You guys have got a whole encyclopedia of them.
Yeah, and it's very exciting what you're bringing to the coast with your knowledge and experience of endometriosis as well. So yeah, well done for advocating for the coast and for the women that suffer from endometriosis. It's incredible.
No worries.
Thanks for that, Jace. And I'm also very excited to lock you in for a date already, because sure, I'll find one for you and send you an email. And yeah, this is obviously way out of my league, but I learned a lot as well. So thank you for that, and thanks for answering my questions. I'm just gonna get my cat out of here.
Thank you heaps, Georgia and Sydney, for putting this on. If this PHN wouldn't exist without you guys, so well done.
I appreciate it. Thank you so much. And I have put the Slido link as well as the QR code. So please fill in the feedback on this session as well, so we can pass it over to Jason after. And I also wanted to congratulate Laura, who I think she left early. She was the Lucky Door Prize winner from last week with a $50 Prezi voucher. So we will choose another lucky member today to receive it for today. But thanks everyone, and we will see you next time.
See you later. Thanks. Have a good day.
Hey guys.
Thank you.